Thank y'all very much for being here today. We will call this meeting to order at 1:10. Thank y'all very much for being here. I would like to call Dan up, Chaplain Baker, up to lead us in our prayer, and then we will do the Pledge of Allegiance. Dan.
Thank you, sir. Let's pray. Dear Lord, we thank you that you hold all time in your hands. We don't really understand time. We just know that it passes us by. But you have a time for everything. And you plan it sometimes not when we want it or expect it, but nevertheless it works out what's best. We ask that you let time be planned appropriately for the care that we're here to give. The timing in the trauma department is very important. We've got to be there when people need us. We've got to be there when people need surgeries, they have heart attacks. We've got to be there in many different situations. But we also have to just be present in the community, to be ready to be there whenever somebody needs to stop by. Almost just like a church bell that rings occasionally, that reminds people that we're here to give care to those that are in need. Thank you, Lord, that you've blessed us in this time. We ask this in your name. Amen.
Would you please join me in the Pledge of Allegiance? I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I have been advised that we have one citizen today to speak. It's Miss Mary Searing, and I would please ask her to come up now and speak. And with the policy of the district, we have 3 minutes, but the podium is all yours, Ms. Searing. Thank you, Dan.
I have been a patient of JPS since 2005. I commend Dr. Del Rosario for stellar patient care. He was thorough and had a great bedside manner. I commend Holly Coker, nurse practitioner, for excellent patient care. She was professional, sensitive, and always had a positive attitude. I commend Lori Gomez, physician assistant at Viola Pitts, for outstanding patient care. She listened to my concerns patiently. I commend Dr. Manny at Viola Pitts for remarkable patient care. He appreciated and respected my input. He told me I was the most prepared patient he ever had. I commend Dr. Rohan Clark, GI, for helping me manage my gastroparesis to the point where I am symptom-free, and for encouraging me to agree to have my first colonoscopy. I commend Dr. Webb, orthopedic surgeon. He offered to give me a steroid injection instead of making me wait for the resident. I appreciate the spiritual support I have received from Reverend Dan Baker. I appreciate the outstanding dental care my daughter and I have received from Dr. Payne since 2007. For the above examples, I am a very grateful JPS patient.
Thank you, Ms. Searing, for your comment. I also just have to say I'm under Dr. Webb's care also, but I don't know if I want the colonoscopy. But
stick to your arm.
Yeah, Dr. Webb's taking care of my. Thank you very much for being here. Next order of business, obviously, is the approval of the minutes. They're before you, the April 13th minutes. There being any discussion, we'll have it. If not, I'd entertain a motion. I have a motion by Mrs. DeBost, second by Reverend Emerson. All those in favor say aye. Aye. Thank you all very much. The next area is, I guess, my comments, and Robert, I'm probably going to step on some of your stuff, but I just want to use 2 words. One is thanks, and the other is pride. One being is the thanks. I want to thank the board. We do a lot of meetings in this district, as many of you know. Last Thursday, we had, if my memory's correct, we had governance, quality, planning. We had 3 complete committee meetings, took up a good majority of the day, and we had 9 of our 11 board members in and out of those 3 sets of committees. So again, based upon y'all's time allocations and your other obligations you have, I appreciate your continued time of doing that. And the last thing is, I'm going to get a little bit ahead of Robert, because I'm going to go ahead and say I'm also, as chairman of the board, I'm very proud to represent this organization in certain things I do throughout the community, but it's not what I do, it's that I represent this board. And I'll just kind of mention several of them, and I think Robert may want to address a couple of them also. But, last Thursday, we had the Seniors Expo in Tarrant County. About 2,000 individuals, senior citizens, go to that each year. It's put on by the county commissioner, Judge Whitley and that group. But I went by just to thank our JPS volunteers. They had a huge turnout, and it was great, and they were doing what they do best. And again, it makes me very proud to stop by and say thank you on behalf of this board to our employees and volunteers that do those kind of things. So again, that was on Thursday. Friday, I had the pleasure of attending the 2017 Excellent in Nursing Awards ceremony. And I only mention that because I know Reverend Emerson was there with me. Many of you have attended that. Many of you have spoke at that event. We had the chairman of the board of the foundation, Laura Wheat, speak at that last Friday. She gave an amazing talk on heroes. I think it's one of those ones. I think Ralph's comments, Ralph, that I think she preaches as good as you do. Excuse me for saying that, but she really gave an amazing talk, and it's very personal because she's had some health issues in her life. And again, Robert, you may want to talk about who actually won or some of those type of things. But a tremendous event. And again, I was there representing this board. As you also know, that as we go on down the road, that we had a last, I may get this wrong, I think it was Monday night. Many of you may have seen the Channel 11 television on what happens in our emergency rooms. And I know it involved, I may get this wrong, nurse, I think it was Hunter Smith, Dr. Gandhi, and the entire emergency room staff. It was a very personal story of someone. And to show you how this all connects, and I won't get into all the details of that. Hopefully many of you saw it, and I imagine it's a link that we have on our system that you can go to. If you haven't seen it, I would certainly, it just makes you proud to see what we do every day here at JPS. That kind of takes me to the last thing I'll kind of end on. Tuesday afternoon, the JPS Foundation actually had their kickoff reception, and many of y'all remember the You Make Lives Better breakfast we had last fall. It was a tremendous success. This year they're anticipating, last year was 500, we're talking 750 attendees this year. And for many of this board that was involved last year, it was a great reception. The JPS Foundation board was there. Several of you came by. And again, I was there to only say thank you for what they're doing because they got tremendous enthusiasm and a lot of good things happening through the foundation too. I know JR's staff is involved in that in communications, and Amanda Stallings with the foundation, but it all comes back together because it just so happened I met Mrs. Utter's sister, who the lady in the Channel 11, her sister came to the foundation, and I think they're now getting involved, and they'll start volunteering and doing things. So again, the JPS family, you never know who we touch and what we do. So to everyone here, I just say thank you, and I'll end on this. And I certainly didn't know Mrs. Searing was here, and I certainly appreciate her comments. I receive, like many people on this board periodically, I get things sent to me, and I'm not going to talk about the illness or anyone, but I just received this yesterday. Dear Mr. Powell, please allow me to tell you about the wonderful care I received at John Peter Smith on April the 30th. If a hospital visit can be wonderful, it can only be contributed to the care and concern of the staff and doctors who treated me. And then she goes on to talk about some individuals and her care, and I don't want to get into her personal stuff. But if I could give the hospital a grade, it would be an A for the outstanding performance. I just wanted to express, and please express on behalf of myself, to the staff and to the people at JPS, my gratitude to those who make JPS a valuable asset to our community every day. So again, I'll kind of end, Robert, and pass it on to you, but a lot of things going on, as we know, at JPS, and sometimes it's just nice to stop and say thank you for what the staff in this room does, what the board does, our volunteers do, and Robert, again, thanks to you and the leadership team, and I'll pass it to you.
Thank you, Mr. Chairman. I appreciate it. We do have a representation of 1,700 of our best nurses that an organization can have, and we've got some of the best of those in the room today. And what I want to do is I want to ask y'all if y'all would stand. These are folks that have taken in some cases, time off for coming in today. We couldn't have everybody here, but we did have a good many of them. You'll see some of the pictures of some of the great care that this organization gives that we couldn't be more proud of. But we have some of the nurses that were recognized for the Golden Stethoscope Awards. And Adriana, if you would stand up, I would appreciate it very much. There you are. Adrian, if you would stand up, thank you so much. Heather, where's Heather? Then we also have Lynn. Where's Lynn? There you go. Thank you very much. And Tessa. We have Tessa here. Kathleen, and I want to make note of Kathleen. We didn't make a big deal about it at the day, but that was the first time that I'm aware of that we had a mother-daughter Golden Stethoscope winner, and her wonderful daughter in ICU, Sarah, also won an award. And Kathleen, would you please tell us what your family means to JPS and vice versa?
Oh, we all live here. There's always a dolly in the house. I have 2 other children. Sarah, she works in ICU. I have 4 children. Sarah in ICU, and then Matthew, he's on P4. Gosh. And my daughter Megan, she used to work site here, actually got me the job here.
Wow.
So at one point we had 4 of us here.
Wow.
Since moved to Plano, she lives in Plano. And I have a son who's a sports information director up in Oregon. So actually right now he's working for the Seattle Storm in Seattle.
If we could just figure out why we need that sports level at JPS, he'd be here too.
Well, you do toss turkeys.
Exactly, we do toss turkeys. Then I also want to make note of Toy. Would you please stand up? Toy is our Rookie of the Year, and if you had been at the ceremony, you would find out the kind of above and beyond care that she provides to our patients. She is incredible. Jerry Ames. Jerry, would you stand up? Jerry is our import from Iowa, wonderful, wonderful young lady, and she is our Nurse Leader of the Year. And then Leslie Haas, would you please stand up? These wonderful people are a real microcosm of who's here at JPS. Trudy, did I leave anybody out? Yes. Thank you. Would you tell me who was it? Who is it?
Amanda Baker.
Oh, Amanda. I'm sorry. Amanda, where's Amanda?
Cal.
Right
There you go.
All right.
Okay. Fantastic. Thank you so very much. Round of applause for these
Amen.
incredible folks. Thank you all so much. I know a bunch of you all have to go back to work. Those of you who don't, please stay.
Thank you again, ladies.
We also have another one of our nurses. We've not had this incredible award before, but the Dallas-Fort Worth Hospital Council recognizes an Employee of the Year. And the Employee of the Year for the entire Dallas-Fort Worth area is Alicia Coombs, and Alicia is here with us today, and you don't get better than Alicia. She is wonderful. Alicia, please stand up. You will find few that are as humble as she is. It wasn't an award that she was expecting. It was great. We had 3 nominees in, and Alicia came back with the gold. But that is amongst probably 60 different hospitals in the Metroplex. And what she does with our homeless project, and what she does with Joel Hunt and Dr. Lonergan and the team is pretty phenomenal. So Alicia, thank you very much. You're a great asset to us.
Hey, Alicia. Thanks, Robert.
I don't.
Excuse me, Robert. Dr. Emerson.
Just one question. To receive that award, Employee of the Year, she was nominated by her peers.
She was.
I just,
She was nominated by her peers here, and then she goes before a review committee at the Dallas-Fort Worth Hospital Council, and they look at the accomplishments and what they do for overall patient care, their impact to the community, and their impact to the region, and she was the overall winner.
yeah, the reason I ask it because I think that's a plus when your peers nominate you.
Yeah,
I think that's
it's incredible, and you saw how fast she got out of this room. She got out of the room quickly for two reasons. One, she wanted to go back to work. She said, please don't have a long introduction of me. And two, I really do need to go back to work. So that's kind of typical of who and what she is. She's incredible. Also, not to leave out our doctors, the wonderful young man that you see on your screen is Dr. Fayette Williams, and Dr. Williams is part of our team. He is the first in Texas and only among 16 surgeons in the country to become board certified in head and neck oncological and reconstructive surgery, and it's powerful that he's here with us. He would have been here for our meeting to be recognized, but he is in a 12.5-hour surgery that he is performing today, so he was unable to attend, but he's a talent, and he's an asset to the organization, so we're proud to have him here. Also wanted to make note to you all, and Pastor Emerson was at the event. We had a few others. In fact, when we won the award for the Business of the Year for Stop 6, Pastor Emerson yelled out so loud that 3 people called me and said, Pastor Emerson is yelling at a meeting. And I said, is he mad? And they said, no, he's really happy. So I can't tell you how pleased and excited that we were. The comment on the street is, we have Stop 6, and it's a great clinic, and Janelle and the team down there that run that clinic do an excellent job, and they're really good people. If you haven't been as a board member to see Stop 6 in a while, you will see a rejuvenation of energy and interest and patient care. They are a model for us. In fact, they've started calling themselves Top 6. They don't want to be called Stop 6 anymore. They're Top 6. And so they're a good crew. And so if you see anybody from those folks, that was given to us by the Southeast Fort Worth Incorporated Awards, and that was a really neat deal. Really proud of them. I wanted to make sure that you all knew that you are invited to the open house at our True Worth. That is a project that we have been working on for a good number of years. You know the history on that, but we're having a ceremony from 4 o'clock to 5 o'clock on May 16th. That's been on our portal, but we'll make sure that you all know that, and we'll send out individual, emails to y'all to remind you. But that's just a come out. It's not a big highfalutin ceremony. It's a ceremony for you to see what we do and how we do it. It's kind of look at the facility and meet some of the team that's going to be down there running that operation. And I'm really proud that we can reach out to our homeless population and to some of the folks in the East Lancaster area that probably need us the most. And we are proudly taking care of a population that needs our help. So very, very pleased with them. Also, this is a great crew that we had from the JPS Foundation. What's important about this is the Colonial Country Club and the Colonial Golf Tournament that they have not necessarily reached out to us in the past. They reached out to us this year and said, we really want you to be a part of some of the festivities that we have and potentially the recipients of some of the benefits that the Colonial brings to Tarrant County. So we had a good group of folks. We had John Murphy from our foundation. We had Jonathan Mock, who is the brother-in-law to the lady that was featured in the news story, and we had Stephen Hamilton, and then the other guy in that picture is a guy named Bill Whitman. I'm not sure that he got approval to go to that because he's supposed to be running operations, but he went out and I heard whipped it up pretty good on the back nine. So pretty good crew, and that was a nice day that we had. And we had one of our patients was our caddy, and that was kind of cool too. So we had a nice situation. You saw the carnival outside. It is one more example of JPS celebrating life. This is, I've discussed with y'all before, this is a challenging place. we deal with a lot of hardships, and we deal with sadness, and we deal with great victories. But we don't have pictures up there yet because it's happening right now, but hence the tattoo on my hand that matches the large one I have on my chest of JPS. But that is we have rides, we have a mechanical bull. If you don't think our trauma's big enough, we want to make sure that everybody gets on the mechanical bull and really gets to see level 1. We have a variety of other things out there. We have the zip line down there, and we have multiple food trucks. It's an opportunity for us to high-five other employees and thank them for the incredible hard work. We try really hard around here not to miss an occasion to enjoy life. Because that's why we're all here, is to protect, preserve, and help life. And so that was a really nice function. Miss Labby, is Miss Labby back there?
She is.
Miss Labby, I want you to come to the podium if you don't mind, because I can make this announcement, but it was the hard work of J.R. Labby in the Communications Department and Amanda Stallings in our foundation that really facilitated and helped with the Channel 11 report. If you did not see what was on Channel 11, you could not see that and comment about the strength and benefits of being a part of JPS. And I want JR just a second to tell you not only what that meant in the Nielsen ratings, but the power of that. So, and what they're also going to do in addition to that. So if you don't mind, JR, tell us a little bit about that report.
I don't mind at all talking about the amazing care that we provide here at JPS, and my team was just a very small part of making this happen. Thanks, number one, to all of the doctors and the nurses in trauma for allowing us to have a camera crew in there the day the patient was originally brought in. So it was a two-part series. One was Real Life in Trauma at JPS, which played a month and a half or so ago. What aired on Monday night was the follow-up story from Courtney Utter, who was the patient that day, who was brought in and ultimately had to have an arm amputated from an accident that she had been in previously. But she was so grateful for the care she received that she wanted to meet the care team in person. And we allowed Channel 11 to come back in. My thanks to Kristen Newcomer, the team member who was the point person, along with Amanda Stallings from the foundation. When the original piece ran, the ratings were off the scale. It was the #1 show on 10 o'clock news on CBS. When the first piece ran, Monday night, when Courtney was able to show the world how well she's doing and say thank you to the care team, it was the #1 segment in the 10 o'clock news across all networks on Monday night. In fact, CBS is going to replay the report on Saturday night this weekend because they had so many people who were wanting to see it. There were 56,000 people that looked on our Facebook page just to see the promo for the piece. So multiply that by the hundreds of thousands of people who watched CBS 11 on Monday night, and we had tremendous positive look at what our doctors, our nurses, our care teams do here every day at JPS, and we are just so humbled to play a very small part in that. Thank you.
JR, thank you. Pastor.
How did we get to Channel 11? How did that?
Well, it's an interesting story that you asked, Pastor Emerson. So Doug Dunbar, who's the reporter, is very interested in marathon running, and Dr. Dwayne, the trauma surgeon, is also a runner, and they met at an event somewhere, started talking. Dr. Dwayne talked about where she worked and what she does. Doug Dunbar became very interested in hearing about that, and that was the entry because one of our physicians was out there in the community participating in something where she had a chance to meet. And so that's where it came. The Real Life in Trauma started in that first piece. So that's how it happened. Thank you.
Thank you, JR. I appreciate it. The other thing that I would say when Leslie Haas has left, but I want to make sure that when y'all met Leslie, she was Nurse of the Year. I'm not sure I articulated that she was Nurse of the Year, but I will do that, and then I will see her later on in tell her once again that she is indeed Nurse of the Year, in case you forgot. So I didn't want to skip that, make sure that you all knew that. The other thing I want to tell you just briefly is we have tried to have this festivity outside for a couple of years now, and the last 2 years, we have had to cancel it because of rain. It only rains 7 days a year in Texas, and we happen to pick the day it rains every year. In fact, last year, if I'm not mistaken, we canceled it, and then we rescheduled it, and it rained on the rescheduled day, and that was in a 45-day drought. What we decided to do this year is pull in the big guns. And we had a special prayer that Dan Baker led, and I'm not suggesting that he has an immense amount of power over anybody else, but I'm saying he prayed, it didn't rain. So I don't know if y'all want to utilize Dan for anything in the future, but it was quite a neat situation, because if y'all were up at 5 o'clock, 6 o'clock, 8 o'clock, and 9 o'clock this morning, it was raining. So we had a good deal. I apologize, Mr. Chair, for that being a little bit longer, but we've had some great victories since we've seen y'all last, and wanted to make note of that.
Thank you, Mr. Early. And again, all great things, and it's great to hear what's going on at JPS. It's just so exciting. Moving along on the business item number 7 on the agenda, and I'll call on Dr. Ziegler at
Thank
this
you.
time.
I want to present the nomination of Dr. Robert Fromm for Chairman of the Department of Anesthesiology. He attended medical school at Tulane. He did his training at Iowa. He has been on staff at JPS since 2011. He's been acting as vice chairman and needs approval for chairman of the Department of Anesthesiology.
Any questions for Dr. Ziegler on this matter? If not, I'd entertain a motion. Have a motion by Dr. Weber, second by Mr. Montgomery. All those in favor say aye. Aye. Dan, thank you very much. Anything else?
Yeah, at the Finance Committee, we talked about the library and what the library of the future is going to look like. Something that happened to me last week, I got an article published in the Journal of Neurotrauma in January, and last week, doing office work, I noticed I'd never received a reprint. So I contacted the Journal and said I'd like to get a reprint, and they said, well, now that costs $40. And I said, okay, and so I quickly went down to the library and was able to get a copy for free. Our library has a interloan service that's free to staff, students, and employees of JPS, and they can just obtain medical knowledge, information. There's a lot of things that you can get the abstract, but you can't get the full text. They have access to that. And there are a lot of these now pay-to-view access that's happening with a lot of journals. And again, the library, because of their connections, they are able to get these services free.
All right.
So on behalf of myself, I'm very thankful to the library.
Well, good. Thank you, Dr. Ziegler. Any other questions for Dr. Ziegler at this time? I would get one of those reprints, Dr. Ziegler, but I probably wouldn't understand and could pronounce the words that's in your article, so congratulations on your article. Next item is Dr. Johnson, if you'd like to come up and give our report on a claim. Good afternoon.
Good afternoon, thank you, sir. Thank you very much. Just a few quick updates. On the acclaimed chairman searches or chief searches, service line chief searches, things are going according to schedule. We are almost complete with interviews. We had one additional applicant, is very qualified, that came up this week, so we'll be scheduling his interviews over the next couple of weeks. But other than that, also within those 2 weeks for family medicine, OB, ortho, and psychiatry, those selection committees will be meeting and ranking the candidates who have been interviewed to make a recommendation for a selection on those. The goal would be to extend the offers ideally by June 1st, but even if we make it on the original time schedule, if we made it by June 30th, we'd be doing well. So things are going well with that. Otherwise, on physician and advanced practice professional recruiting, just an update there. We have, since we started Acclaim, filled 32 positions. Many of these positions came as open positions whenever Acclaim started, although we have had some folks transition out. We currently have 40 remaining open positions. 31 of those 40 positions have one or more identified applicants that are vetted, and at some point in the process between scheduling interviews and waiting on them to sign a contract. So recruiting is going very well. Physician engagement survey, Acclaim continues to work hand in hand with the medical staff and with our executive administration on prioritizing and putting action plans and actuating things to address our opportunities in the physician satisfaction survey. Physician well-being, on May 5th, I'm happy to announce we launched the Physician Effectiveness Project. We've talked about that in a few committees here. Laura Burnside gave an update, I think, at Quality last week. She did. It's a wonderful program. It's a web-based platform developed by physicians for physicians. We are on the physician well-being track. So the thought there is it's organized in a learn, do, share model. So you go online, you learn something, you try out a new technique that you learned in the module, and then you share how it worked. To give you an example of how within the first week, one example of things that happened, our chair of pathology went on and although our track is related specifically to physician well-being, we have access to many other learning modules in there. And she, for whatever reason, the learning module that is intended largely for primary care related to how do I get the most out of a patient visit? How do I get patients to identify early on in the visit, why am I here? What can you help me with? And it really relates largely to asking the patients, connecting with them on a level of, rather than where's your pain, what are your symptoms, connecting with them immediately on what's most worrisome to you today, that type thing. After doing that, our chair of pathology had a thought that, not related necessarily to patient care visits, but when I get a specimen from surgery or one of the clinics, I need some sort of a clear, concise, quick communication on what am I looking for, what am I worried about. So taking it in a totally different way, so she wrote up a story on what she thought we could do to apply that knowledge to a different scenario. Well, Steve Beeson, one of the national experts in this, that is running this project, immediately responded back to her and said, yes, here's some great things. So anyway, lots of great stuff from this. We're very excited about it. Are there any questions? That concludes my report.
Any other questions for Dr. Johnson? If not, thank you so very much. Appreciate it very much, Dr. Johnson. All right, we'll get into committee reports and actions on those. The first being the Finance Committee report. And Mr. Montgomery, do you want me to say how that went? Or
Please do, yes.
Mr. Montgomery was out of town and asked me to sit in and chair finance. And so obviously it certainly wasn't as professionally as normally handled, but we stumbled through it. But anyway, everything is on the portal, the full numbers. One thing we are going to do that came out of that finance meeting, and Steve, we'd already discussed this previously. I think at this point in time, we don't need to go through the whole thing. You've got access to it. It's on the board portal. But Sharon, we thought, would give just kind of a snapshot of kind of where we are as the district. And so, Sharon, I think, Steve, with your permission, we'll have her come to the table. And again, this is not the full report. You have access to all the consolidated and all that in your package and on the portal. But we thought it'd be kind of, if there's any direct questions, Sharon will be here, Steve, to answer those questions. So, Sharon, it's all yours.
All right, good afternoon. This will be a much condensed report than what I give at Finance, so if you have any questions, feel free to ask them. The combined income statement has been modified a bit, and beginning in April, it will look different going forward. So the blue line that you see on your screen, I've added the budget number to the combined statement. So this is the way it will look in the future. So this will be the report that I review at the board level from here forward. But the numbers are the same. So for the hospital this month, you'll notice kind of midway down the page, our income from operations was $511,000 compared to a $1.1 million budget. The top side, we had very good volume numbers this month. Admissions were up by about 5%, and outpatient revenue was up by about 2%. So strong volume, strong patient mix there. As you remember, our uncompensated care accruals have been reduced based on what we feel like we're going to be receiving by about $833,000 a month. So those two things offset. And down in the expenses, we did have some higher physician expenses and purchase service. For a claim this month, we did lose about 1.6 million compared to a budgeted loss of just over 700,000. Most of that loss was up on the top side of the income statement, resulting from lost revenues because of the high out PTO from physicians being on vacation during March. So that was the driver in a claim, along with some expenses in locums for neurosurgery and their purchase service and contract labor, and some one-time expenses in the May Street Administration Building. So year-to-date, the hospital income from operations is 3.9 million compared to a budget of 6.8 million. Again, that deficit mainly due to the uncompensated care. We're anticipating that to be below budget, along with some of the offset by some of the price increases that we've seen with positive payer mix this year, some slight offset. And a claim has had some one-time expenses of about 2.4 million that we did not anticipate in their budget year-to-date, along with some volume underages as well. And we are looking into a claim, and we'll report back later, as we discussed in finance, at a much more detailed level. Any questions?
I have a quick question.
Yes, sir.
For the, so if we have a high level of physician out, do we augment them with the local tenant, or how does that work to fill in the gaps?
If, and I'm speaking for people that I can't see looking at me behind me, but I'm gonna answer with what I know from my experience. If you have intermittent out, like if you're just gonna be out for a week or a couple of days, you typically do not have locums come in and try to fill those spots. If we know that we're gonna have a long-term outage, like when we're trying to recruit to fill a spot in specialty care, we will have locums come in. But when a physician will just be out for vacation, we would typically not bring in a locums to fill those slots.
Oh, I see. For me, if you can help me understand this, so we have about 41 open positions. Are they open, but augmented by local tenant to fulfill the needs?
So, from what I understand, in a claim.
What I'm trying to get to is that, is the revenue we're expecting, is that with a full pledge with local tenant to fulfill the work?
Say that again, DT.
The budgeted piece.
The budget that we have, right? Like, let's say we have the revenue for a claim, about
Right.
7.3. Is that including FTE fill-in, or is that less 41 open position?
So the budget that we have, remember that the acclaim budget, when we set the budget, we really did not expect to onboard all of the traditionally, the physicians that were traditionally employed by UNT. So the budget is not quite apples to apples. But the gap that we have is a lot of open positions that we are currently recruiting for, and a lot of those are in primary care. There are some specialty care areas that are open that we are filling with locums. The biggest specialty that I'm aware of is neurology. that we're filling with locums. The rest of those are open, and you hear us talk about the backlog in the primary care clinics. And those are the ones we're trying to resolve.
I'm gonna call that $1.5 million in the bracket is an investment for now.
Yes,
So if we have 41 of those positions filled, that is another $10 million add on to that line that we
No,
have, right?
no,
I
the-
mean, 1 million plus a month, because it's 12 months.
correct. Your question would be, if we were to fill the positions, would the loss get bigger
Or is our revenue going to come up?
effectively?
Uh-huh.
No, the loss does not get bigger the more revenue we generate if the positions are filled. So, a lot of the loss that we're having right now is because the physicians that, so on the salary line of a claim, the salaries that, for the physicians that are here, at least for this 1 month, because of the PTO that were taken, there was a lot of non-productive time. And if you think about March and spring break, and there were just a lot of physicians that were unproductive for the month of March. The way the budget was built is for, it was kind of an annual budget divided by 12, because we did not have any historical information to actually go back and try to do any seasonality. So without that seasonality information, we just divided it by 12. Because without any better information, you just have to use what you have.
What I'm trying to get to is that if we have 41 that we can't fill, where do those patients goes to? Or do we really need those 41?
You do need the 41
Right,
because there is
I know
such
we need
a
the 41, but what are we
backlog
doing
of
with our third
patients.
patient right now that are not going to be able to get into the system for treatment? That's what.
Correct. So is your question the fact that you're not sure that you need the 41 if
I'm-
they're not filled now?
I'm more concerned is how do we take care of the needs of the community when we have almost 15% of our workforce not being filled?
Sharon, point of clarification. DT, you're referring to not the financial piece, which we've talked about here. You're actually talking, maybe Dr. Johnson could cover this. You're actually talking about who's handling that patient base,
It's
because
a-
we have 41. I'm not putting words in your
Right.
mouth, but I think that, Dr. Johnson, you may,
And then.
that's more of an operational question, I think, than a
And
financial.
then the other one, trying to close the gap, is that if that's our revenue, and it varies very little, or as we add more doctor, then do we need to look at to see how things operate? Because if you add another $1 million a month to the bottom line in terms of fulfilling 41 positions, at an average about $250,000 each, some more, some less because of specialty. But would that be something that we need to be prepared to deal with when the next year's budget coming in? Because we actually is missing $12 million.
Yeah, and DT, I don't want to speak for Sharon here, but we did have an acclaimed our board meeting of which Chuck chairs, and that entire financial model based on, I guess you'd say, assumptions and expectations when the budget was given last year. Sharon has an entire team that's in the process of getting into that exact, correct me, Sharon, that exact question about what is the true revenue expense, not only associated with a claim, but again, a claim is just one part and parcel to the overall district. And there used to be, I think, some cost associated maybe at the district level that's now over in a claim. You're going through that entire, correct me, Sharon, you're going through that entire process in anticipation of the budget.
Correct.
Okay.
So you're kind of a step or two ahead, I think, of the report that we're going to have prepared for you within the next
Yeah.
3 or 4 weeks. But the short answer is that the reason for this month, no, you would not expect when you fill the next 41 positions that you would necessarily have to extrapolate another a loss for the 1.5 million that you see this month. I think that's your initial question. What we're working on, as far as a further explanation for a claim, is where do we feel like we're gonna end up fiscal year 17? Then what would be kind of our baseline for 18? And then what is the strategy that we're gonna be laying on to start to build a budget for budget 18? So those are the 3 steps that we're working through right now for a claim.
And DT, again, you may recall, because we had a budget meeting scheduled for and we said until we get those numbers and variables complete, so Sharon's gonna be coming completely back with a whole where we are with the acclaimed budget and where those costs have been allocated, which is a different question. Dr. Johnson, again, appreciate you coming up. I think DT, and again, DT, correct me, but the question is, if we've got 41 open positions, and even though you're in the vetting process going through, where's the patient base?
Understand.
So
And
that's
Mr.
more
Nguyen, one
operation.
thing that may help here is one of the strategies that we utilize is using internal additional coverage to cover for some of those 41 positions. So a scenario there would be, I've got a primary care physician that works 4 12-hour shifts. They work in a place, so they work 48 hours a week. They have 1 day a week off, and many of our facilities are also open on weekends, right? On Saturdays. So we have made part of most of their contracts, those who are willing, an additional services rate. So once they work beyond the time frame that we've contracted them to work, we pay them a rate that's slightly an overtime rate. It's slightly higher than their regular rate, but it's much lower than what we would have to pay a locums provider to come in and fill that gap. So we use we use our own people to fill in those gaps at an addition, so that comes out as a slightly higher salary in the report, right, for those people. And it does cover a good portion or some portion of that gap, and it does it at a lower cost than bringing locums in to do it.
But when you do that, in the first year as we get started, set up the benchmark and all that stuff, is that going to throw off your WRV or the work RVU and all that stuff? Because you get walked in, you get new patient that they've never seen before. Should they be spending more time? And then as we trying to adjust to see if we pay them fairly on the work RVU and all that stuff.
Absolutely. It's something that we are keeping a very close eye on, and we're doing our best to separate out those WRVUs to see, one, because there are two things you can do with that. One, you can follow and track, as you're saying, to make sure it doesn't skew future WRVU based salaries. But the other thing is you can use it to say, are these 41 positions or these 40 positions justified, right? Are we accumulating enough RVUs in that additional work to say, yeah, we really need this to be another full-time provider?
Because I'm concerned a little bit because we have a pretty excellent program on the family practice. But if we go to a totally RVU without any outlier adjustment, then we focus and they don't do OB.
Absolutely,
So
absolutely.
That's the concern I have on the program itself on the long term.
On the family practice with OB? Yeah. No, absolutely. We have that program in addition to some of the others operationally. We really looked at the WRVU model, and some of those programs will have a hybrid WRVU, some of those coverage-based specialties. So that OB labor and delivery is really a coverage-based thing, right? They're there for 12 to 24 hours. And they can't necessarily control what comes through the door or what doesn't come through the door. So we are adjusting for those specialties that have a large coverage-based component to accommodate that piece of the coverage-based practice that they perform.
Good deal.
So, and they seem very happy with that model.
Dr. Johnson, I think Dr. Hire had a question also.
I hate to show ignorance with my questions, but I'm going to ask them anyway. If that number, that's 441 million there, no, that's operating expenses. Operating revenue, 445 million, that's a quarter of the year. You compare that to what I remember our total annual budget is, it's 1/2 of the budget for just 1/4 of the year. Am I seeing something wrong?
Well, remember that we're not really on a calendar year. Our fiscal year starts October 1, so you are looking at half of our...
I'm looking at half a year.
Yeah.
That explains that.
That's right, yes.
Okay.
All right, Dr. Johnson, thank you very much. Any other questions for Sharon? And again, the idea being, and Steve and I spoke, was to give you a snapshot. Again, if you have any questions, So we'll, unless we hear otherwise, we'll do this monthly. And Sharon, thank you very much for the update. We'll look forward to the other information coming up on a claim, so.
Charlie,
Yes.
not to steal someone's thunder from a report coming up soon, Mr. Petty, but from the Blue Ribbon Committee, there's some real information being gathered that's pertinent to this, in that even just of the demographics and the market share we expect to serve, we've got room to expand, significant room to expand, and that was just reported to us this week. So everybody's seeing that go forward. In case anyone who's hearing this amongst our community is curious, we are working on a bond issue that could help solve some of this.
As usual, Dr. Lowry, you're ahead of me. I was going to ask the Blue Ribbon Committee for an update later, but that,
Sorry.
I appreciate y'all serving on that.
That's a
So
start.
there being no additional questions in finance, I'll move forward. I would mention one other thing. Sometimes when you can't make the meetings, you'll call. In this case, I chaired finance. And DT, you had a question, I think, about making sure compatibility of the library. And even though, again, Dr. Ziegler's mentioned about the use, we had David Mendenhall come up and make sure, and I know there's been some tests, so if there's any questions about the interface of that, all that's supposed to have been worked out. So I'll let you know, those questions they were asking finance, so that was covered. So there being no additional in finance, I will go to you, Dr. Lowry, for quality.
Quality did meet this month. We had a great deal of business to catch up on, to reiterate the comments about the physician burnout and the programs going forward there. That's all in process and a good thing. I don't think I have other actionable items to report.
All righty, thank you so very much. Any questions for Dr. Lowry reference to quality? If not, I know planning's been very busy, Trent, so I'll come to planning.
Planning has, and Dr. Lowry and I attended the meeting, as he mentioned, the day before yesterday. That document's not yet on the portal, but I'm sure it probably will be by the end of the week. The presentation this week was a follow-up from HMA, but it was also, there was a deployment ambulatory strategy that was given to us. This was by Percival Health Advisors, and we've not yet seen them, but first time we've encountered their work. But as Dr. Lowry said, that process was about trying to understand what the ambulatory capacity is versus the ambulatory demand. And I think the two things that I would say stood out the most, and that are, again, in perfect alignment with everything that this board has researched over the last several years, is that our delivery system as it is today cannot meet the demand. It can't meet the demand today, and it can't meet the demand in the future. And so knowing that there's just never going to be enough bricks and mortar that we would ever be able to build to meet that demand, the question becomes what else needs to be done in the areas of primary care and preventive care that hopefully reduce that downstream requirement. And Percival had some good ideas. There was a lot of data and statistics. I think the Blue Ribbon Committee has a huge job, because that committee is being asked to come up with recommendations from a stream of data that's just gigantic. And so I think our biggest challenge, and I think Dr. Lowry and actually Commissioner Wynn and Dr. Lowry and I sit right next to each other, and our conclusion was that even when it's finished, we're going to have to do a lot of paring down to really put this into something that is measurable, that can make sense going forward. But in terms of our goal to make sure that that committee was well informed relative to where this county is in terms of its ability to provide the need, that's met. Because I think everyone on that committee would tell you they've been shocked at the demand for service versus the capacity to give it, and I'm amazingly impressed that JPS has been able to do what it has done with the resources that we have. So it's been very positive, I think illuminating on a lot of different levels, and I think when it's all said and done, it'll probably end up coming back to us and saying, okay, from all of this, Board of Managers and Commissioners Court, what's going to be the final top 4, top 5 priorities, because it's going to be a long, long list.
How's your anticipated timeline for the committee?
Every meeting, we make the meetings longer.
Amazing how that works.
So far, the plan seems to be, instead of starting at 2:30, we need to start starting at 1:30. And we've already added one, and I'm not even going to speculate at this point in time how many more. I think one of the challenges is going to be not to let the committees creep too far on scope.
Good.
Because we talk about everything from transportation and things that are really not within the JPS purview. They're perfectly pertinent when you look at the healthcare delivery system, but they're not necessarily going to be anything that we're going to be able to do anything about at JPS. So I think our challenge is going to be to not let the scope get so broad and try to attack so many different needs that we end up not meeting the timelines. But I know GK's goal is to get it done as fast as possible, and still certainly our plan is 3 more meetings and we should be ready, but I'm not gonna make any bets right now.
Question.
Yes, sir.
On these, at these Blue Ribbon meetings, is the organization operating with the understanding that one can never, ever meet the needs of a situation like this, in a system like this? There's always a matter of triage, a matter of saying these are the important things that we're doing.
Yeah.
And that there are other, I mean, although this may be why we're here, there are other needs by other taxing agencies and authorities in our lives. And so we can't give all of our money to this need.
Yeah, I think that is clear. I think there's been, Mr. Norad, some illumination on the part of some of the members that really didn't have a grasp of the demand as it is. I mean, when we started talking about the behavioral health care demand, for example, and the fact that we should have 700 and something beds, and when you recognize the fact that JPS is sort of the Lone Ranger in that market when it comes to our patients and many others, including the jail and others, I think that was illuminating to people, that this demand is so great that we can't ever meet it. We cannot spend enough money to meet that demand. And I think they're coming to grips with that. I think the question is going to be within the realm of financial capacity as well as service capacity, what are going to be the highest priorities for JPS? Because I think some may have come into the process not recognizing what you just said, and that is we will never be able to spend enough money to meet the need completely.
So somebody during the committee had said we could make a 900 bed or 1,000 bed, and it would still get filled in record time, and there'd be additional demand.
That has become overly apparent on every single meeting. And so it becomes a matter of strategy and priority and process, not a matter of trying to, under the illusion that we can somehow meet these needs. It is really about becoming more efficient, using our dollars in the most efficient way, and what we can do that don't necessarily require bricks and mortars to help meet that need. And so I think that part of it's very positive, and I think the committee I think they've been coached well, and the data that they've been given has underscored everything we've been looking at for several years.
But Trent, I know they talked about JPS picture, but wouldn't we say that's the picture of the county itself?
Yeah, I think, Reverend Emerson, that's one of the keys that we're going to have to stay focused on, is that, the data is not necessarily filtered only as it pertains to JPS. We talk about the percentage of population under the federal employment level, poverty level, right? And that's a big number. But then we have to divide that number down in terms of what the current JPS patient load is and what that JPS projected patient load is going to be. So I think it's been relevant discussion. We haven't come in there and said, here's the whole county need, JPS, you should fix it. We've said, here's the JPS portion of the county need. Here's the projected portion of JPS's capacity over the next several years, and we shouldn't assume that we're going to be able to, meet all those needs. But the interesting thing is, even within that confined scope, even within that refined number of the JPS patient load, it shows very clearly we have a long, long way to go, or JPS won't be able to maintain the same level of services that we do today over the same percentage of that population that needs that care. So it's clear there's going to have to be bricks and mortar, and there's going to have to be process improvements just to stay where we are. And that's the part that we have to, I think, continue to focus on and recognize as a very important consideration when we go into things like bond committees.
Because the longer we stay as we are, the deeper the hole gets.
Absolutely. And I think that point is being made. Dr. Lowry, I mean, you've been sitting there listening to the same thing I have.
But,
Totally agree. The other thing that the three of us put our heads together with after the meeting is, this is really sort of a two-headed monster we're trying to slay. The hospital, the physical plant here on South Main is one. The 75% of the issue described to us this week is ambulatory care and people in the community. That's not going to happen on South Main Street, but it's part of the system. How do you handle both ends of that? And again, I would just reissue what Trent said, that nobody has the vision that we're going to have this totally solved and everybody covered. That's the ideal, but we're going to have to work around other plans. It's the wish list. It's the wish list, exactly.
I think we may want to open up a little bit to see, do we want a really huge campus? Or do we want, as the demand shift from people with insurance with less means of insurance? Like at one time, Harris County is looking at buying one of the hospital from Memorial Home and convert that to, so it's the way, just like a different, in a other industry, you look at build versus buy. And you take advantage of tax and all that stuff also as well, depreciation, everything else.
There's a lot of discussion about potential solutions that especially on the ambulatory side of the equation, but there's also some, I think there's gonna have to be some more education on that, because one of the things that came up this week was, we have all of these vacant urgent care centers now. Because there's urgent care centers all over the place. And Scott Reel and I were talking afterwards, and it was like, if you look at the size of those centers versus what the JPS population health model requires in terms of a clinic, sounds good, but that won't work. And so there's several things I think we're going to have to continue to stay vigilant on when it comes to making sure that we're focusing the resources in the right place.
Oh, no, wait a minute, it's not the ambulatory side, but maybe potential down the road, a second hospital type thing, build versus buy type thing, or lease it from somebody else.
Attending the American Hospital Association annual board meeting in D.C. this past week. You heard the big cry and concern about where do we really see the hospital's role from intervention versus prevention. How do we get to the community to try to help it to be a healthier community so we don't have to keep building brick and mortar? And so I think that's something that comes all the way back home that we'll need to look at.
And I think, Reverend Emerson, that's crucial for this committee, because one of the things we need to be able to do is, when it's all said and done, we need to show the impact of JPS to the entire county,
Right.
where the county is.
Right.
And if we're perceived as doing something that only results in a focus on this campus, and leave out
Right.
the potential improvements that need to be made regarding access and the clinics, and the ambulatory presentation made that crystal clear, then we probably alienate a pretty good segment of folks that would otherwise support
Very
where
true.
we're going. And I think that's one of the things we've got to focus on.
Well, and one quick speech from the practical side of practicing medicine in this community, and I will stop after this point. There's an amazing naivety in this country, including within our government and healthcare institutions, that all these people we want to take care of are going to regularly check on their blood pressure and their blood sugars and what have you, when in fact, they're crisis oriented. And as soon as they start getting bad sick, they're going to pop in. So the goals and the ideals versus the realities are sometimes way different.
Just make a rule they have to.
And then they'll come.
So, long answer to your question.
No,
Sorry
Trent.
about that. We took a
Well,
long time.
now, there's a lot of work going on, as I said earlier, and I was making the thank yous. I mean, again, a lot of service going on in various things. Thanks to you and Roy for serving on that. Anything else in planning at this time?
No, sir.
Okay. Last committee update, which is, again, part of your package, is governance. Roger's not here. He's actually out of town, and as I count, there's 10 of us here, so we would have had all 11 if he'd have been here, but there was nothing, I'm going to say, we met, and Dorothy, you were with me. I don't think there's any other thing major than normal stuff that's here in your package. So all that being said, we will move along to item number 10 on the agenda, which involves Mr. Adams, I think you're going to make that presentation.
Correct. About this time, well, actually, February of last year, we began this process of dealing with what since 2002 has been the group purchasing organization for this hospital. 2002 until 2015, that organization, which is University, it was the University Health System Consortium, was a partnership, and in 2015 chose to convert to a stockholder-owned company. That created a legal issue for many of the partners of the University Health System Consortium, which are public hospitals across the country, because most of the states in the country have a constitutional prohibition against a public entity holding stock. We had a very short timeline to deal with this, and the JPS Foundation graciously became our placeholder while we resolved this. We now have before you two agreements, an agreement of declaration and trust that's between the hospital district and Plains Capital Bank of Texas. Plains Capital is an affiliated organization of our investment advisors, First Southwest. Trent Petty and Charlie Powell opened that door for us to visit with them, and you have an agreement of declaration of trust for consideration. It's been on your board portal. In addition, a document that's a companion document is an assignment agreement that's between the JPS Foundation, the hospital district, and Plains Capital. That's basically transferring the 7,637.8581 shares of Vizient stock in trust for the hospital district to Plains Capital. And I would recommend your approval of those two documents.
Does it take two separate motions?
No,
They both be
they go
approved?
hand in hand.
If there's any question, and I think prior to this vote, DT, correct me, because you serve as a liaison between the foundation board and here. The foundation board has already approved this, subject to this board approving, it's my understanding.
Well, the Vizient board also has approved this, subject to this board approving as well.
So again, just to make sure, and I say DT serves as that liaison between these two boards. So if there's any questions for Neil, we'd certainly entertain those at this time. If not, I'd entertain a motion. Yes.
Is there any financial cost involved in this?
Yes, there's a $1,500 initial fee and then $1,000 a year, which is extraordinarily reasonable for the bank to step up and take care of that.
Yes,
Okay.
it's for us to maintain the asset.
Exactly.
That's correct. Have a motion by Dr. Weber.
Second.
Have a second by Ms. DeBose. All those in favor say aye.
Aye.
Thank you so very much. Thanks, Neil. Oh, I'm sorry, DT.
I'm going to recuse myself from voting, just to be certain, because I was one of the executive at MedAsset, which Vizient bought, so I'm
Gotcha.
abstaining.
Appreciate that very much. Time you get that, DT Recrease. Thank you very much. Motion passes. The next is the consent agenda. You've all had access to that information. If there's no discussions or anything relative to any of those, I'd entertain a motion for the consent agenda.
So,
I have a motion by,
second.
I have a motion by Mr. Montgomery and a second by Reverend Emerson. All those in favor say aye.
Aye.
Thank you very much. Any legal?
Yeah, I have one item pursuant to Chairman Montgomery's policy and finance is to announce and at least remind you that you have 23 contracts for the month of March that were under $200,000 that were posted and you were alerted to on your board portal. Okay?
Okay. At this point in time, I think we do have just a couple items for close. We have a couple items for close, so at this time being 2:20, we will convene in closed session here in just a few moments. Take about a 5-minute break. Thank you. We'll go ahead and reconvene back in open session at 3:15. And I think I'd call on Dr. Ziegler to present the credentialing and privileges.
We have the list of people for appointments that are approved by the credentialing and MedExec, and need approval from the Board of Managers. Recommend approval.
I have a motion by Dr. Weber, second by Reverend Emerson. All those in favor say aye. If there's not any other business, we will stand adjourned. Thank you all very much.